My name's Sue Thomas, and I'm delighted to welcome you to this webinar on SMA, a new era in SMA. There have been significant changes over the last few years in the management of SMA, and we have pulled together from the Neurology Academy a group of specialists that are working in this specialty. Last year, they started to work on a pathway for both paediatric and adult management of SMA, which we have launched the paediatric pathway already, and the adult pathway will launch during the summer of 2021. And just to try and highlight some of the aspects of management and early referral for patients with SMA or potentially who have SMA, we are running this webinar today in order to inform you a little bit more about the subject. So we've got three excellent speakers who are going to update you. We've got Dr. Vasantha Gowda, who is a paediatric neurologist from the Evelina London Children's Hospital, Dr. Min Ong, who is a paediatric neurologist at the Children's Hospital in Sheffield, and Lisa Edel, who is a specialist respiratory neuromuscular physiotherapist from Great Ormond Street. So I hope that you enjoy each of these presentations. Dr. Vasantha Gowda is going to start us off, giving us a little bit of information about this new era of management in SMA and what that means for you as clinicians.
Hello, everyone, and welcome to the webinar on spinal muscular atrophy in infants, a new era for management. I'm Vasantha Gowda, a consultant pediatric neurologist at Evelina London Children's Hospital. I look after pediatric neuromuscular patients, and I also run pediatric neuromuscular clinical trials. I'm going to be talking about recognizing spinal muscular atrophy in infants and also the current treatment options available for children with SMA. I'll start with a bit of basic sciences to begin with, and we'll quickly move on to recognition of SMA. Survival motor neuron protein, or SMN protein, is crucial for the health of lower motor neurons. Lower motor neurons pass the signals from upper motor neurons to the effector muscles. SMN1 gene produces 85 to 90% of the SMN protein in the body. SMN2 gene produces an isoform or a truncated protein because exon 7 is excluded from the final transcript due to splicing. This isoform or truncated protein is unstable and degrades quickly. So SMN2 gene produces up to 10 to 15% of the SMN protein needed. If there's a mutation in SMN1 gene, it results in lack of functional SMN protein, which leads to death of lower motor neurons. As a result, the muscles atrophy. This is spinal muscular atrophy. So homozygous deletions of exon 7 in SMN1 gene result in 95% of SMA, and point mutations in this gene cause the remaining 5%. SMN2 copy number correlates to some extent with the severity of SMA. The incidence is about 1 in 10,000 live births. The carrier status in UK is about 1 in 40 to 1 in 60. This is the second highest cause of death in autosomal recessively inherited conditions after cystic fibrosis. This table shows the SMA phenotypes, their usual age of symptoms, the maximum motor function that can be achieved, and the SMN2 copy numbers that we usually see. SMA type 1 is the most severe and the most common form of SMA. Up to 60% of SMA is SMA type 1. This is characterized by rapidly progressive weakness, inability to sit independently, respiratory insufficiency, and bulbar difficulties, all leading to either permanent ventilation or death before the age of 2 years. This shows the natural history of SMA type 1. As you can see, around the age of 8 months, there is 75% survival. However, there are only 8% surviving by the age of 20 months. With regards to investigations, nowadays we go straight for the genetic test, which has a turnaround time of about 10 days at our center. This may be slightly variable at different centers. This is almost 95% sensitive and 100% specific. We don't usually need the CK or the neurophysiology nowadays. I'm mentioning these because we keep coming back to these abbreviations in the rest of the talk. Top intent, HFMSE, HINE, and MFM32 are all different types of assessment, neuromuscular assessment that we use in our clinical practice and clinical trials. Just a bit about the timeline. Wernig and Hoffman described SMA in 1891 and 1893 respectively. Then there was nothing until 1960s when there was further classification of the phenotypes. In 1992, this was localized to chromosome 5, and in 1995, the SMN gene was identified. In 2019, we had the first license for gene therapy for SMA in USA. For those who are interested, this is the Standards of Care for SMA paper, which looks at all aspects of care for children with SMA. Recognizing SMA early is very important, as the sooner these children start treatment, the better the outcomes are. In any floppy baby who's alert in the face, consider SMA. In babies who present with chest infection and or feeding difficulties, look for floppiness or hypotonia and muscle weakness. If you do find a baby like this, refer them to the local pediatric unit who can arrange for urgent genetic testing for SMA. At our center, the turnaround time for this is about 10 days. The local pediatric units can then refer these children to the tertiary pediatric neurology or neuromuscular team for treatment. In the cognitively able older children, if there is gradual loss of motor skills, consider SMA. Coming to the treatments, there are 3 that we need to talk about. The first one is Nusinersen, the second one is Risdy Plan, and the third one is onasemnogene or Zolgensma. So Nusinersen is an antisense oligonucleotide. It acts on the SMN2 gene and promotes inclusion of the exon 7. This in turn promotes increased production of the full-length SMN protein. This Nusinersen is administered intrathecally through lumbar punctures. So the children are given loading doses, 4 loading doses over 2 months, and they need maintenance dose every fourth month. These are the key trials looking at efficacy of Nusinersen: NDA trial in SMA type 1, Cherish in type 2, Nurture in pre-symptomatic children, as well as Shine, which is an open label extension trial. Nusinersen has been licensed for treatment of children with SMA type 1, 2, and 3. In the UK, we started the expanded access program in January 2017. In 2019, managed access agreement was announced by NHS England. So the NDA trial is the first one that shook the SMA world with the results. 121 patients took part. In the treatment group, 50% showed improvement, and there were none in the placebo group. There was a huge improvement in the CHOP intent scores in the treatment group, 73% as opposed to 3% in the sham procedure group. Overall, the risk of death or needing a ventilator was reduced by 50% in the treatment group. This is an important slide because this shows the difference in the probability of ventilator-free survival or just survival in the in children who started the treatment before the age of 12 weeks in the top 2 graphs, and after the age of 12 weeks in the bottom 2 graphs. The blue line is treated children data, and the black one is the sham procedure group or the placebo group. So in those who received treatment before the age of 12 weeks, there are better outcomes for both ventilation-free survival and survival in general, but the gap between the two is not so much if the treatment started after the age of 12 weeks, as you can see in the lower two graphs. Cherish trial looking at the efficacy of Nusinersen in children with SMA type 2, again demonstrated good motor progression in these children. And a point to note is that in those children with disease duration of less than 25 months, there were better outcomes. SHINE open label trial confirmed the same data. Nurture trial looking at pre-symptomatic children with SMA showed the following results. They were all treated before the age of 6 weeks. Well, their treatment was initiated before the age of 6 weeks. And it showed that 22 out of the 25 children were able to walk with assistance. And of those 22 who walked, 17 walked independently and maintained that ability to walk. The treatment was well tolerated and no major safety concerns were raised. I'll come back to the side effects shortly. Here we are. So most of the side effects were related to the intrathecal injections themselves and the logistics of administering the intrathecal injection. We do monitor the renal function and the platelet counts routinely, as we do with any other drug in this group, antisense oligonucleotides. Of note, there were some cases of hydrocephalus reported in the first year when Nusinersen was licensed. However, we have not had any more notification regarding hydrocephalus, so it is not a common occurrence. The next drug to mention is the Risdy Plan. This is a selective RNA splicing modifier. Just like Nusinersen, this acts on the SMN2 gene, promoting the inclusion of exon 7, leading to the production of functional SMN protein. This is taken orally, this is not administered through an intrathecal injection. Because it's taken orally, there's uptake by several systems, not just the central nervous system. This is an overview of the various different trials of Risdy Plan. Firefish in type 1, sunfish in type 2 and 3, and jewelfish is an open label extension trial, and rainbow fish in the pre-symptomatic group in whom the treatment is started before the age of 6 weeks. Firefish, looking at the SMA type 1, showed that 95% of infants were alive at 12 months and maintained the ability to swallow, and 89% were able to feed orally. And almost a third of these patients were sitting without support for 5 seconds by the age of 12 months. Sunfish trial showed similar results in type 2 and 3. And the jewelfish trial is ongoing, and the data will be published shortly. This is another key trial. This shows that in children who were treated before they were symptomatic, before the age of 6 weeks, that is, 4 out of the 5 patients were able to stand and walk independently. And the CHOP intent scores were 64 out of 64 in 4 and 63 in 1. Side effects were minor and did not need discontinuation of the drug in any of them. They were mostly what you commonly see with SMA, upper respiratory tract infection, fever, pneumonia, and so on. In the animal trials, there were reports of irreversible retinal degeneration. However, none have been reported so far in the human trials or in real life. Coming to the last one, the gene therapy. Essentially, this is introducing the genetic cargo into the cells using either viruses or polymers. If you use viruses, it's called transduction. If you use polymers, it's called transfection. Several viral vectors can be used: lentiviral, retroviral, adenoviral, and adeno-associated viral vectors. Adeno-associated viral vectors are preferred because they don't integrate into the patient genome, because they stay as episome outside the genome, and they cause low immunogenicity. So Zolgensma, or onasemnogene abeparvovec, is a non-replicating recombinant AAV vector that uses AAV9 capsid to deliver a fully functional human SMN transgene. This crosses the blood-brain barrier and achieves a high level of neuronal transduction. And as I said before, it is designed to reside as episomal DNA in the nucleus and does not enter the genome, and is expected to be stably expressed for an extended period of time in the post-mitotic cells. This is not known to cause disease in humans. The first trial recruited 15 children, 3 of whom received a lower dose and 12 received a higher dose. The dose that was given to the 12 patients was subsequently considered the treatment dose. Of these 12 patients, 11 out of them sat unassisted, 9 rolled over, and 11 fed orally. 2 walked independently. And in the last data cutoff in 2020, 2 more were able to stand with assistance. All of them were alive and no milestones were lost. 6 of them did not need any respiratory support daily. SPRINT is another key trial looking at the pre-symptomatic group. They looked at children who had 2 copies of SMN2 gene and also 3 copies of SMN2 gene. In the 2-copy group, 11 out of the 14 achieved the primary outcome measure of more than 30-second independent sitting. And in the 3-copy group, 8 out of the 15 achieved the more than 3-second standing primary outcome measure. Of note, in both groups, there were several children who were still within the WHO window of normal development for these particular milestones. So there are more who could reach the primary outcome measure with time. STRIVE is an open label extension trial which is ongoing, and these patients as of 2020 are still showing prolonged event-free survival and increases in motor function and milestone gains. The STRONG trial has been aborted. This was looking at the intrathecal injection of Zolgensma. This has been halted due to concerns regarding dorsal root ganglia toxicity in primates. With regards to side effects from the gene therapy, vomiting and fever are common related to the infusion. We do see hepatotoxicity, particularly transaminitis, which usually settles down after a couple of weeks. Thrombocytopenia is seen commonly as well. However, this is usually asymptomatic and recovers fairly quickly. Thrombotic microangiopathy is a risk, but in very small numbers. Elevated troponin I was seen in the clinical trials. However, the echocardiogram and ECG performed at the same time showed no abnormalities. Viral shedding happens post-infusion, and therefore families are advised to double bag the nappies and wear gloves while handling bodily fluids for 4 weeks after the infusion. Vaccines are another practical consideration in view of the steroid therapy. We advise no live vaccines for 4 weeks before starting the steroids, and for 3 months after stopping the steroids. The gene therapy is given under cover of steroids, which is started a day before the actual gene therapy infusion. Further considerations, I mentioned the dorsal root ganglia toxicity in primates with direct intrathecal injection of Zolgensma. We do not yet have enough data about transgene immunogenicity and transgene expression over years to come. Going back to why we need to diagnose SMA early, and the reason I was mentioning the pre-symptomatic data for all these trials, this shows the neurodegeneration in the type 1 SMA. As you can see, 95% of lower motor neurons are lost by the age of 6 months, and there's a rapid decline even before the age of 6 months. And all available treatments have demonstrated better outcomes in children who have started treatment early, particularly in before the age of 6 weeks. With all these treatments, SMA type 1 has changed from an almost certain fatal condition to a condition in which long-term event-free survival is possible with likely acquisition of important motor milestones. And SMA2 has changed from a slow and progressive condition to a stable over long-term condition. Therefore, it is important to recognize SMA early so that we start treatments early and improve their outcomes. I'd like to thank Neurology Academy for providing this opportunity to raise awareness of SMA, talk about recognition of SMA in the primary care world so that the children get the best of the treatment available. Thank you.
So many thanks to Vasantha for that presentation. We're now going to move on to a discussion about some case histories of infants that have been diagnosed with SMA. And I'm going to introduce now Dr. Min Ong, who is the paediatric neurologist from the Sheffield Children's Hospital, to update you here.
Thank you. So in this presentation, I'll first like to just put on my disclosures. And I will be talking about children presenting with SMA in infancy and would highlight 4 cases. The first 2 would be children with SMA type 1A, which is the more severe form of SMA type 1, presenting usually in the first 2 weeks of infancy. And there is also a type B, which usually presents presents with symptoms by 3 months, but may be diagnosed later. And type 1C is presentation of symptoms just before 6 months of age. And I also have 2 cases of children with type 1C. So it's just to contrast presentations of children with SMA type 1 without treatment. So the first case, 1A, a natural history without any treatment. And the second case, 1A with early treatment. And then the third case being a later presentation of child with SMA, but with later treatment because treatment was not available then at the earlier stage, and a child with 1C, but treated earlier. So the first case was born at term, post-term, and uneventful pregnancy, but does have a family history of SMA, with the parents being consanguineous, and the child's cousin had actually died from SMA itself. At 4 days of age, the child had breathing abnormalities and was actually admitted to hospital, but subsequently was discharged because they felt that the child had recovered. However, parents felt that there was worsening of breathing and also noted some poor limb movements. And unfortunately, at 5 weeks of age, had been admitted to ICU because of a parainfluenza, presumed lower respiratory tract infection. At that point, the child had been seen by the neurology team and was diagnosed with SMA. Because of the early presentation, the child was thought to have type 1A SMA and potentially a type 0, which is the more severe form that often presents immediately after birth to about 1 month of life, as the child had symptoms of breathing abnormalities at 4 days of age. The SMN2 gene copy number is 2, which usually is in keeping with a SMA type 1 presentation. At that point, discussion about treatment and management was made with the family, and just to note that there was some language barrier. However, it was agreed with the family that in the best interest of the child, because of severe presentation, the child would be extubated and palliated to the local hospital. At 10 weeks of age, the child continued to be an inpatient in the local hospital, needing NG feeding. but had not needed respiratory support following initial oxygen therapy. At 10 weeks also, because the child seemed to continue to be stable, treatment and management was discussed again, particularly the available option at that time of Nusinersen. However, the parents decided that it was like an operation, the procedure of administering Nusinersen itself, and so declined this. We had a physiotherapy assessment score for infants with SMA called CHOP, and this score was 16/64. Children with SMA type 1 will never achieve a score more than 40 usually. However, unfortunately for this child at 12 weeks of age, it had a respiratory deterioration and died. Our case 2 is a type 1A SMA child who was treated early after Nusinersen was introduced in the UK and available on the NHS. So it's a term baby, uneventful birth, apart from finding of a left clicky hip. There was no family history. It was the first child of the family and was very well until 5 weeks of age, where the family noted that there was reduced movements in the limbs and sought help from GP. At 7 weeks, the GP was had reviewed the child again because of parental concerns and thought the child was floppy and was admitted to the local hospital. There are multiple investigations were performed, including nerve conduction testing, which then went on to instigate the genetic testing for SMA. This child again was found to have SMN2 copy numbers of 2, and this was diagnosed at 9 weeks of age. Just to note that this child received multiple investigations, and we should in fact just be testing for genetic changes of SMN1 gene if we suspect that the child has SMA. During the admission, local team was put in place for the child, such as physiotherapists, speech and language therapy, community nurses, respiratory assessment, clinical genetics appointments, and neurology review. The child was started on BiPAP and also received appropriate vaccination, such as RSV vaccination. At 11 weeks of age, when the child was reviewed by the neurology physiotherapy team, was found to have no head control and no anti-gravity movements. 12 weeks of age, Nusinersen was started. And as you can see, the CHOP score, the assessment for infants with SMA, was done consecutively. So the initial CHOP score was 6 at 3 months of age. And then following Nusinersen therapy at 9 months of age, 32, and increased to 44 at 15 months of age. Like I said before, a CHOP score of greater than 40 is unheard of in children with SMA type 1 who are untreated. The child himself had was felt to be stronger in his arms, grabbing, transferring, moving his legs, however, was not still rolling. There was episodes of increased secretions during that period of time following Nusinersen therapy, and this was managed with antibiotics, but he has not been unwell, not requiring any hospital admissions. Currently, the child is on prophylactic antibiotics. BiPAP was also started prophylactically, only at night, and the child receives cough assist with regular suction by the family. He is also partially NG fat and is awaiting a PEG insertion. We have also recommended a spinal brace for upright postures as he is getting stronger and wanting to participate more, and so more active in the upright posture. So these are some videos. The one on the left is a video of him at 1 month of age. And you can see that he is not moving very much at all. His upper limbs seem to be moving more than his lower limbs. In the middle photo, it's just a picture of him being on BiPAP and NG tube 2 weeks into Nusinersen treatment. And the video on the left is him at 7 months, which is 4 months post starting Nusinersen. And as you can see, there's improved arm movements with anti-gravity movements at the elbow and slight anti-gravity movements at his shoulder. Video at the left is a video at 13 months of age, and parents are doing physiotherapy or stretching his Achilles tendon. And as you can see, he has improved arm movements. His breathing is abdominal and he has a barrel-shaped chest. And at 14 months, after 6 doses of Nusinersen, you could appreciate the anti-gravity shoulder movements and also some leg movements at his knee, which is without gravity eliminated. And the final video on the right is him at 15 months using his hands. But at the end of the video, you would be able to see him actually moving his legs. There you go, against gravity. So the next two cases would be cases of less severe SMA type 1, which is the 1C. The first one being a child who was treated later because Nusinersen was not available until she was much older. She initially presented because of concerns in motor skills less than 6 months of age, and the family had sought medical opinion from another country prior to seeking medical help in this country. And at 1 year 3 months of age, she was found to be hypotonic, had a marked head lag, and sat with a very rounded back and needed support, and also was areflexic. So not being able to sit is a identifier that the child, if they have SMA, would have SMA type 1. She also had multiple investigations and finally SMN1 genetic testing. So just a gentle reminder that if you suspect a child has SMA, the genetic test is the investigation that will clinch the diagnosis. Because of her having the less severe form of SMA type 1, she actually did not have any respiratory involvement up until 18 months of age. She also had no chewing or swallowing problems. However, because of the diagnosis, it was planned that she had input from speech and language therapy and respiratory team as well. At 3 years of age, she then required chest physiotherapy and also went on to NIV overnight because of an episode of lower respiratory tract infection requiring high dependency care. She was provided with physiotherapy and the appropriate orthotics such as hydrotherapy, sleep system, gaiters, and a standing frame. And at that point, she still had some active lower limb movements. And in children with SMA, generally their lower limbs are more affected than their upper limbs. She could move her lower limbs by like putting her foot on her knee and using her arms to reach out for small toys. Unfortunately, around 3 years of age, she developed a scoliosis, and we tried to manage it initially by putting her in a lycra suit and also a sleep system. Unfortunately, because the sleep system can be quite rigid to some children, she did not tolerate this very much. In terms of her swallowing, she managed to be able to take food of all textures, except those that are very hard. And we investigated her swallowing formally with a video fluoroscopy. particularly when her weight started tailing off, which is a common scenario in children with spinal muscular atrophy. She then went on to have a PEG-J insertion, and she also suffered from constipation, which is quite a common presentation or symptom in children with SMA. At 6 years of age, she required overnight NIV, also had a cough assist device, which she uses regularly, and also requires constant suctioning. And at that point, later on in the year, she started on Nusinersen because it became available in the UK. Unfortunately, her scoliosis gradually worsened, and it made it quite difficult to get into her spinal space to deliver the Nusinersen therapy. At 7 years, 9 months, she had growing rods fitted following spinal surgery, and she had her wheelchair remolded. So on this table, you can see that her CHOP score, which, as I mentioned before, is an infant SMA motor assessment, has gradually been increasing over time, over 2 years following Nusinersen therapy. And HINE-2 is another scoring system for motor assessment in slightly older children with SMA. WHOMM is the WHO motor milestones, and 0 means that they are unable to sit they are unable to sit unsupported, and 1 would be a score where they would be able to sit unsupported. So she achieved that after the first maintenance dose. Unfortunately, at 1 year, since just over 1 year after starting Nusinersen therapy, she had her scoliosis surgery because, she had her scoliosis surgery, and that made it more difficult to give Nusinersen therapy. She also then suffered with tightness and spasm around her hamstrings following the surgery, and that affected her CHOP score. As you can see, it dipped to 38. Following several Nusinersen treatment requiring general anesthetic, because it was difficult to get into the spinal space, she was started on Risdy Plan on the early access medicine scheme. So this on the left is a picture of her following Nusinersen Nusinersen therapy, but prior to her going on to, having the spinal surgery. And as you can see, she is sat, unsupported, but with a scoliosis. And on the right is a video of her showing that she has improved upper limb movements, where she would be able to lift her hands to her mouth sufficiently for her to bring a small cup to her mouth. So she was also able to feed herself, whereas prior to Nusinersen, she was unable to feed herself at all. The fourth case is a case of type 1C SMA, similar to the previous case, but treated earlier. So this girl was born at term, also uneventful delivery, and was bottle feeding well. But parents noticed that her legs seemed to not move so well at around 4 months. And unfortunately, she was only seen by the community pediatrician at 10 months. And at that time, she was sitting, if propped, and lost her head control when prone, and was not rolling. She also had a weak cry and an ineffective cough and spluttering on water, but she has not suffered from any chest infection, and like the previous child, was also constipated. She was diagnosed with SMA at 10 months with also 2 copy numbers of SMN2 gene. Typical to the presentation of SMA type 1C, she did not have a bell-shaped chest but had abdominal breathing. Speech and language therapy referral was made, and also vaccination advice was given, such as flu vaccine and RSV vaccination in the first 2 years of life. This is a video of her on the left, showing she was unable to sit unsupported, and this is about at 10 months of age, around the time of the diagnosis of SMA. Her mom would need to put a hand behind her to support her sitting. And the video on the right is of her just after diagnosis of SMA, so about 11 to 12 months. And as you can see, she has abdominal breathing. The shape of her chest is very normal. And although she's moving her hands quite a bit, she's not moving her legs very much at all. So she had series of motor assessment following Nusinersen therapy, and she was started on Nusinersen therapy soon after diagnosis, and then had a series of motor assessments following that as well. And as you can see, her CHOP score increased to a current state of 50, and 50 at 1.5 years, and now because she's more mature, she goes on to the Heine 2 motor scoring, and that continues to increase. She's also able to sit unsupported following the loading doses of Nusinersen. She's now 3 years old and is able to reach overhead. She can roll, she can pivot when she's sitting unsupported. She has some anti-gravity movements in her legs, and in fact, she's self-propelling in her wheelchair very, very well. So these are pictures of her. From the left to the right is as time goes on. So on the left is probably at around 1 year of age, sitting, as you can see, requiring support with a rounded back. In the middle picture, it's about 1.5 years of age, and she can sit unsupported well. And on the right is her in her little self-propelled wheelchair and using her hands to feed herself. But you might be able to appreciate that she has a very slight scoliosis developing now. So since her diagnosis, she's had a few chest infections every year, but not required any hospital admission. We tried her on non-invasive ventilation at less than 2 years of age, but she did not tolerate the mask. However, she's now able to tolerate this nightly, and she has had, in the first 2 years of her life, RSV vaccination and every year flu vaccination. She also receives chest physiotherapy and is on prophylactic antibiotics. She continues to be able to orally feed with no issues, and her video fluoroscopy was normal. She had a mild scoliosis, which was found at 2 years of age, and she's now in a sleep system and also a spinal jacket. And this video just shows how well she is doing in terms of her upper limb strength. She will demonstrate to you that she's able to lift a heavy bottle into the fridge, and also how she is very proficient in using her wheelchair. So in summary, early diagnosis, early supportive management, early disease-modifying treatment can help. Early diagnosis by health visitors, GP, pediatricians in hospital, and also in the community by clinical genetics team. Early supportive management by the respiratory team, physiotherapists, speech and language therapists, dietitian, orthotics, OT, and portage, as well as surgeons for inserting a PEG can help. And early disease modifying treatment by the neurology team with help from the pharmacist and potentially involvement of theatre staff, nurses, and anesthetists does help in this group of children. That's the end. Thanks.
Many thanks to Dr. Ong for that enlightening presentation. We're now going to move on to Lisa Edel, who is from Great Ormond Street. And Lisa's going to talk to us about a very important aspect of the management of paediatric children with SMA, and that's respiratory management. So over to Lisa for that presentation.
Thank you so much for that introduction, Sue. So today I'm going to be talking about respiratory management for children with SMA, and specifically about early recognition of complications. These are my disclosures, and we're just going to have a little look at SMA1 in particular, because that's really where we see most of the respiratory difficulties in the small children. So just in terms of the presenting condition, looking at severe limb and trunk weakness, you have oral bulbar issues, including difficulty feeding, oral secretions and swallowing difficulties with a failure to thrive. In terms of respiratory specifically, we're really looking at a general increased work of breathing, and we're going to talk about the signs and symptoms of that. You discover these children can develop a bell-shaped chest, paradoxical breathing with a poor cough and recurrent chest infections. And we're just going to delve into that a little bit more detail now. So in terms of increased work of breathing, there's quite a few things that we're looking out for. So the first is head bobbing, and that really comes from respiratory effort. You'll notice the child, as they breathe in, they kind of move their head backwards and forwards to increase their ability to take the breath. We see nasal flaring, and then you can see a picture of the nasal flaring down here. So if you look at the picture on the left, that's normal nostrils, and then the flared nostrils are on the picture on the right, where the child opens up the airway as much as possible. You could get upper airway grunting, tracheal tug, which is when you notice on their neck that they're taking a slightly stronger breath in. You can get recession, that can be subcostal or intercostal. And then this video will demonstrate that. So you can see that the child's just dipping below their rib cage, and you can see that they're working that a little bit harder. Then if you think about they can increase their respiratory rate quite significantly, you might notice some cyanosis, so blue around the lips, and quite often they'll have poor feeding because they're working so hard in terms of their respiratory function that they struggle to coordinate feeding and breathing at the same time. So if we move on to thinking a little bit more about bell-shaped chest, so this is very typical in SMA1, and there's a variety of pictures for you. So in cartoon form, you can see that you have a normal shaped chest where the ribs are nicely spaced out. And then with SMA, you get a narrowing at the top of the chest wall and splaying at the bottom. And that creates what you can see in the pictures by that bell-shaped chest. So you can see in the little girl, you've got quite narrow at the top, and then it splays out. And then if you look at the X-ray as well, that shows you again that you've got a narrow chest wall at the top with widening at the bottom, giving that typical bell-shaped chest. And that really is because the diaphragm in SMA is relatively well preserved, but they do get very weak intercostal muscles, and that really is what equals that bell-shaped chest. Another thing you might notice quite clearly is paradoxical breathing, and I'll show you these two videos. So you can see that the abdomen comes out as the child's breathing in, and they're really working quite hard. And this is in a child at baseline without any respiratory distress. This was prior to us putting this kid on non-invasive ventilation. And then this video is much more forced. You can see that they're really dipping below their ribs, and it's a really forced breath. And this is actually in a child who's acutely unwell at this time. So it's that opposite movement of the abdomen to the chest that you wouldn't ordinarily see. So for me, I always find the stages of a cough really interesting. So if we think about what a cough is in us, and that really is thinking about the 4 stages. So if you think about the airway irritation, which is the first stage, which is where our sensory pathways detect that there's an airway irritation in secretions. The airway irritant receptors are found in the greatest concentration in the posterior tracheal wall, carina, bifurcation of the large airways, less so in the distal small airways, and there are none beyond the respiratory bronchioles. You have to have both chemical and mechanical receptors present, and that is what triggers that airway irritation of your brain to say, oh yes, I need to start the process of a cough. Once that happens, you then get your brain sending signals to trigger that deep inspiration. So it's that ability to generate a deep breath in. And what happens with that is where you have your deep breath in, that causes your increased elastic recoil of your lungs. So we all have that, and it's naturally occurring. So when you take that deep breath in, your lungs have a natural elastic recoil that then spring them back in, which helps improve your expiratory flow. So you get airway irritation followed by deep inspiration. You then get glottic closure and compression. So what happens is your glottis closes, and that then enables your lungs to build up intrapulmonary pressure. After that stage, you then move on to expulsion. So within expulsion, you get your expiratory muscle contraction and your glottis opens, and that is where you get your expiratory flow generated. So you get a really high velocity cough, which helps you move secretions. So just thinking a little bit more about what happens within your lungs is that you develop a turbulent airflow, which is what actually causes you to cough and clear secretions. So it's actually at the site of the compression and the turbulent airflow, which is what moves the secretions up and out of your airway. You actually have to have a higher expiratory flow rate compared to your inspiratory flow rate. And if you're looking to move secretions, that needs to be at least 10% higher in your expiratory flow rate compared to your inspiratory flow rate. Your peak cough flow, you're looking to exceed a flow rate of approximately 30 to 60 litres per minute to overcome your shearing forces, which is how the mucus is then moved away from your lining of your chest wall and therefore clearing the secretions. Now, obviously, that then means that if you've got really sticky, thick secretions, you need a higher force to be able to create a higher shearing force to pull the secretions away from the chest wall. So if we think about where it goes wrong, there. So there's quite a few phases where it can go wrong in SMA. So the first is that you have an abnormal inspiratory phase. So this is really related to the reduced muscle power and the body's inability to vary the inspiratory volume. So if you think about neuromuscular weakness, the inspiratory muscles use about 2 to 3 times the amount of oxygen compared to unaffected individuals. This is also linked to a stiffened rib cage, areas of microatalesis, plus or minus the presence of a scoliosis. And again, remember that the diaphragm is relatively spared in SMA. And studies have shown that increasing your inspiratory volume alone can actually increase your peak cough flow. So, which is obviously the ability to then produce an effective cough. So you need to find an appropriate method to create a maximal insufflation capacity. Next phase is that you've got impaired bulbar or glottic function. So by having an impaired bulbar function with altered dynamics of swallowing, this leads to a pooling of oral secretions and it increases the risk of pulmonary aspiration. And again, this also links to problems with glottic closure, and you can't build up that compression in your lungs, which is needed to then increase your expiratory flow at the end. And if we think a little bit about your weak intercostals and abdominals, that then prevents you having that effective expulsion, which leads to effective expiratory flow. So to be able to improve your cough strength, you must be able to improve your expiratory flow bias. Now, it's all very well and good speaking about that, but the key part in this is that you have an impaired cough. So all of these things lead up to the fact that you then can't cough and clear your secretions. Now, we're just going to think about why that's really important. So if we think about the science behind secretion clearance, so by an inability to clear your secretions relates to the fact that you then develop acute and chronic respiratory disease. That's associated with impaired mucus production, so increased mucus production, impaired mucociliary transport, and an impaired cough. So we'll just talk about each one of these individually. So if we think about increased mucus production first, so human bronchial balance consists of mucus cells, serous cells, and water secretion. In healthy people, this produces a protective amount of mucus for the lower respiratory tract. However, if you have hypersecretion, too much mucus is produced, and this becomes pathological and no longer protective. This then, in turn, causes a decrease in your mucociliary transport and an increase in mucus plugs. So if we move on to mucociliary transport, so this is directly impacted by your mucus production. But the key part about your mucociliary transport is that your hydration state in your lungs is really important. So the airway in your lungs, you have something called an airway surface layer. And that is a fluid layer which is controlled by ion channels that regulate the mass of salt and water on the airway surface. So essentially what can happen is if you have dehydrated airways, then your airway surface layer reduces and your cilia sit in that airway surface layer. If the surface layer reduces, your cilia can't beat as effectively, which therefore they can't move as effectively and they can't clear secretions as well. And then if we move on to the impaired cough, we've already spoken about this in the previous slide, but it's believed that the mechanical forces from coughing and from other expiratory techniques cause those shearing forces we spoke about and reduce the viscoelasticity of the secretions in the airways. It's a bit like if you think about a ketchup bottle. So if you've got a ketchup bottle and all the ketchup is sitting at the bottom and it's really thick and sticky sitting at the bottom, you need to then give that a really good shake to be able to clear what's sitting at the bottom. And your lungs are very similar. You have to give it a really good shake and give it a really good cough to be able to move the stuff that's sitting at the bottom. And if we just think about why it's so important to clear secretions from the lungs. So if you think about the ketchup bottle analogy and the secretions sitting at the bottom of your lungs, that in turn can cause retention of secretions. That can then cause increased work of breathing. It can cause a ventilation perfusion mismatch, so therefore their gas exchange won't be as effective. And the retained secretions can also cause an increased infection and inflammation risk. And this is something we're seeing in the cohort of SMAs that are now surviving longer as a result of treatment, that a lot of them are growing more long-term bacterial infections that don't clear as easily. And part of this is as a result of long-term secretions.
Many thanks for that really enlightening presentation, Lisa. I think you'll agree that all three presentations today have been really informative and update on the SMA era of management that we now have presenting to us. If you'd like to increase your knowledge of SMA, we will be running in the autumn a base camp education programme for clinicians and allied health professionals on the management of spinal muscular atrophy. So do keep an eye out on the Neurology Academy website for more details of that. To end the webinar today, we're going to show you a short animation that's been developed with the help of Dr. Vasantha Gowda that really stresses the importance of early referral for babies that have SMA. So I hope you enjoy the presentations. I hope that you'll enjoy the animation, and do please keep in contact and watch out for the forthcoming SMA base camp. Thank you.
Spinal muscular atrophy, SMA, is a rare, genetically inherited neuromuscular condition that causes progressive muscle weakness and loss of movement due to muscle wasting. There are different forms of SMA, but around 1 in 10,000 babies are born with the condition. In the UK, this means 65 babies will be born each year with the condition. 60% of these will have the severest form of SMA, type 1. Treatments are now available in the NHS, but a delay of just a few weeks for treatment initiation can have a huge impact on outcomes. It's really important to refer early if you suspect SMA in an infant. Delays to treatment may mean the infant develops significant disabilities. Let's look at 3 babies showing symptoms of SMA that should be followed up urgently. Mia was 6 weeks old and had a chest infection. Her mum took her to see her GP. On examination, her GP felt she wasn't moving her limbs as well as she should and referred Mia for an urgent hospital appointment where she was diagnosed with SMA type 1. If an infant has a chest infection, check for floppiness and muscle weakness. If in doubt, refer urgently to the local paediatric service for further evaluation. Every day counts. Ben was just 3 weeks old. He was very sleepy, and Mum told her GP he was also floppy and not feeding well. Ben was referred urgently to the paediatric neurologist, where he was diagnosed with SMA type 1. With feeding difficulties, look for floppiness and muscle weakness. If in doubt, refer urgently for further evaluation. Every day counts. Aurora was a full-term baby who at 6 weeks was alert and smiling and seemed well, but Mum said her movements were getting less and less. Her GP said he would review her in a couple of weeks to see how she was progressing developmentally, but a week later Aurora developed a chest infection and was admitted as an emergency to hospital where she was diagnosed with type 1 SMA. Every day counts. It's vitally important to recognise the presentation of SMA type 1 in babies and refer promptly to secondary and tertiary services to initiate further evaluation. With floppiness, muscle weakness, delayed motor milestones, consider SMA type 1 and refer urgently to the local paediatric service for further evaluation. With chest infections, feeding difficulties, look for floppiness and muscle weakness. If in doubt, refer urgently to the local paediatric service for further evaluation. The earlier the baby can be seen, the better the prognosis. Treatments are now available for spinal muscular atrophy. Every day matters in the countdown towards diagnosis and treatment, which can usually start within days of confirmed genetic diagnosis. Remember, every day counts. Learn more about the SMA treatment pathway by visiting neurologyacademy.org. Find out more about SMA by visiting the SMA UK charity website at smauk.org.uk.